I chair CECOPS. What we're going to do is give a short presentation, and then there'll be some questions, which we've been already pre-prepared, but I hope we'll have time for questions from the audience. Our panel of experts, on your right, and coming towards me, in number one position we have James Lawrence, who is the Director of Health+Care UK, a world leader in equality, safety and risk management. Next to him we have Pauline French, my Director of Croydon Care Solutions. Then James Lampert, Commissioning Manager, Community Support, Kent County Council. Alan Rosenbach, Special Policy Lead, the Care Quality Commission. And finally, Brian Donnelly, who's the founder and CEO of CECOPS. If you want more biographical details, they're in the conference program, so you don't need me to give them to you. So Brian, would you like to tell us all about CECOPS, please?
Okay, thanks very much, Bert. I'm just going to do about 5-6 minutes, a bit of background about community equipment. I was going to stand over there, but Sir Bert took my place, so I'm going to have to sit here.
Is your mic working, Brian?
Can people hear me okay? Okay. Okay, I'll just start really with a bit about community disability equipment. You will know a lot of this, but 1 in 10 of the population use disability equipment and various assistive technologies. Now, obviously that number increases as the older the population is. In excess of 500,000 nurses, therapists, carers, technical staff assessing for, providing and maintaining equipment. Disability equipment, it meets therapeutic, mobility, communication, educational, prevention, reablement, and various needs right across the spectrum. And it supports both the medical and social models of disability. What do we mean by disability equipment? Examples, it's quite a broad spectrum, but home nursing, hoists, ventilators, aids for daily living, shower chairs, for example, children's equipment, postural support, sensory impairment equipment and communication aids, minor and major home adaptations, routine and specialist wheelchairs, and lastly, telehealth and telecare. So right across the spectrum, I suppose it would be easier to say equipment that is in the community. It's provided by local authorities, NHS stores, hospitals, continuing healthcare teams, special schools, retailers, private sector suppliers, care homes, hospices, domiciliary care providers, third sector organisations and housing agencies. The importance of disability equipment, hugely underestimated. It's vital for disabled children and adults and older people in promoting their self-determination, their independence, their dignity, their safety, their social inclusion, their quality of life and control over their own lives, things that the rest of us take for granted and indeed expect. A very familiar quote by the Audit Commission, their review of equipment services in 2000. If a medicine was discovered with a similar cost profile, it would be hailed as the wonder drug of the age. And how true that is. This is just an example of the importance from a financial perspective. This was a review, a paper carried out by Francis Haywood, an excellent paper, Better Outcomes, Lower Costs, on behalf of the Office for Disability Issues. For a 30-year-old man, savings in residential care costs of 1.6 million over an assumed life expectancy of 20 years were projected as a result of investment in home modifications. That's a saving of £80,000 per year for one individual. Again, this is a review I carried out myself, an independent review. If only 1% of the 12 million pieces of equipment delivered each year in the UK fails to be delivered appropriately, and it results in a secondary episode of care, a fall, pressure ulcer, hospital admission, care home admission, it could unnecessarily be costing the care economy in excess of £5 billion per year. But we need to break down the silos to release that. So to assist in maintaining quality of services, the new Code of Practice for Community Disability Equipment has been written. It's essentially a quality framework for commissioning and provision of services, including the clinical and professional responsibilities of therapists and nurses, for example. Michael Mandelstam wrote concerning the code, it's a reminder of the basics, rights, responsibilities, and safety. CECOPS, about CECOPS. CECOPS is a not-for-profit community interest company, manages a registration and accreditation scheme for the Code of Practice for Community Equipment. We also provide training and various other aspects. Our stated community objectives, community interest companies have got their own regulator. Our stated community objectives are high quality and safe community equipment services being available and accessible to all who need them, children and adults who are disabled, the elderly, and to support the carers and professionals who provide services to them. So it's quite broad. CECOPS itself, it's a self-regulatory model which incorporates indirect regulation. In other words, it meets other regulatory requirements, Health and Safety at Work Act, CQC's essential standards, where equipment is concerned, medical device regulations in one place. This is just some of the support we've had already from various organisations. We've got a lot more in the brochure. We can see there Care Quality Commission, the Chair of Care Quality Commission, Health and Safety Executive, ADAS, Chartered Society of Physiotherapy, Royal College of Nursing, and College of Occupational Therapists. So quite broad in terms of the support that we've had. Okay, Bert, that's me. I'll hand it over to you now for the panel questions.
Right, many thanks, Brian. Delightfully succinct. Just, I got involved in CECOPS because of my concern about disability equipment. And of course, I use it all the time. In fact, I live on the stuff and spend a fortune on it. And I've always been quite surprised at how people often prescribing equipment for me never actually knew about the equipment available, never knew how to assess me. And I think, well, what's going wrong here? And then you get battles like, can I have a £300 cushion? No. So will you pay £25,000 for the pressure saw? That's not my budget. Hang on, it's a health services budget. Someone's paying for it. So equipment becomes very important. And then I see people using as basic as the wrong wheelchair. And for people who live in wheelchairs, a wheelchair is a bit like a pair of shoes. If it's the wrong one, it doesn't fit you. It is really uncomfortable. And you're uncomfortable the whole time you're in it. And so the right wheelchair becomes important. That's just basic equipment, let alone the more specialist stuff. So that's why CECOPS is there, trying to improve standards and improve the service, both for the professionals and for the end user. We have a number of questions. So the first one, of course, is how does it fit in with the current care agenda? Integration, just been listening about integration of care. Prevention. Any of the panel want to have a go at that one? Sure. Fire away.
I'm very confident and comfortable that it does fit with the integrated agenda, because the equipment itself, it isn't a health piece of equipment specifically, it isn't a social care piece of equipment, it will help people with those kinds of long-term conditions, degenerative situations, people who are aging. It's a support to people. And certainly locally, we've been very successful, whereby general practitioners, nurses, and social care specialists have worked together. And we've got past the hurdle, that famous question of, is it a social care bath or a health bath? Is it a social care bed or a health bed? As long as it's doing the job, as long as it's keeping people at home, and as long as it's keeping them safe and well, it really fits with the integrated agenda.
Yeah, I think it's a really interesting question, actually, about how equipment fits with integration, because I'm sure for those of you sitting in the room, you'll know that through the Integrated Community Equipment Services Programme, lots of the health and social care stores were brought together quite a number of years ago. And of course that looks different across the country, and I'm sure that however stores were set up probably almost 10 years ago now. That's probably evolved and changed. Some of the conversations that are kind of live for us at the moment in Kent is actually, that was all very good and it was really good at the time, but is it meeting the needs of the way that the health and social care system runs at the moment? So for those of you that were in the room for the session just before this, the director of the Royal Borough of Kingston and the CCG was talking about avoiding hospital admissions and reducing admissions to residential care. Now, equipment is going to be really key to stopping people from going into residential care, but also might stop them from going into hospital or to expedite a discharge from hospital. Now, for those of us that are working or those of you that are working at the front line, actually getting hold of the equipment in a timely way is really important. Now, I remember my professional background was actually as an occupational therapist, and I remember the days when it might have taken weeks, maybe months, for something as simple as a bath board or a raised toilet seat to be delivered. And I didn't know as a practitioner when things were going to turn up. And then several years ago, there was a government target put in place to say, actually, that's not good enough, you've got to do it within 28 days. And then, of course, a few years ago, that was brought down to 7. Now, to wait 7 days for a piece of equipment to stop you from going into hospital isn't good enough. And the sorts of conversations we're having now is about, well, how can you get equipment to somebody maybe within half an hour? And how can equipment providers respond to that level of demand? How can we work with domiciliary care organisations to actually deliver fit, maybe, those sorts of pieces of equipment? I was only yesterday having conversations with the Ambulance Trust about falls prevention services and what kinds of equipment might they be able to carry on rapid response vehicles in response to falls, maybe at 2 o'clock in the morning. How do you get equipment into people that quickly, at the right time in order to prevent those admissions?
Okay, let me move on to the next question then, and we can bring other people in. How can you improve clinical and financial outcomes?
Should I?
And do you want to have a go at that?
Should I have a go at that?
Yeah, by all means.
Yes. I think it partly also just picks up the points which have already been made in response to the first question. I think all the evidence that exists, and there isn't a great deal of it, but the evidence that does exist demonstrates that actually having accessibility and availability to equipment that's really essential to people's requirements makes a really significant difference. And some of the work around this indicates and shows and demonstrates that very often these are not major requirements that people have. I mean, obviously there are cases where people will benefit from having access to the kind of equipment, assistive technologies, which I don't really believe we've either scratched the surface of or focused on in quite the right way of making these accessible to people. I'm sorry, but I just wanted to make the point in response to the previous question, which is, of course, one of the things we need to do to liberate the way in which equipment can be used to help people meet and experience better outcomes in their day-to-day existence, of course, is to give people control. And I think one of the things that's really quite important in this is the extent to which not just personal budgets in adult care, but personal health budgets, which are being trialled, need to be pulled together, and people need to be given the opportunity to utilize those resources in a very flexible and considered and thoughtful way, as very often people do. So I just wanted to make that point. But I think all the indications are, from the evidence that does exist, is that where equipment and assistive technologies are made available, it just can be transformational for people's lives, and they'll self-report that, and all the evidence indicates that it does make a difference. I think we've got less of a handle on what does this mean from a financial perspective, but you kind of have a sense that if those outcomes are the right outcomes that are being delivered for people, because they are so transformational, you almost intuitively sense, well, there's bound to be a cost benefit that accrues from that, because people are more likely to be able to live the lives that they want to live, which means probably outside of long-term care institutions, able to live in the community in which they reside. And so you have a sense that the financial consequences of this are likely to be felt personally, but also, I think, more widely across the system.
Ryan, do you want to come in?
Okay. I think there's an important aspect as well, which is easy to overlook in terms of equipment, and it's some of this equipment allows children to access the curriculum. It's essential for early years development, particularly where you have children with profound physical disabilities, and that is a complex area with a lot of bottlenecks and delays. So it's quite, there are other more obvious, like safe and timely discharge and post-discharge recovery. But I think there's not so obvious areas like children accessing school and for people accessing work, which is a financial benefit all around.
Okay, thanks. Let's move on to the third question. I'm very conscious of the time, unfortunately. It's a very short session. But what are the risks? Coping with demand, safety in the community?
Can I just start on that one? I think one of my personal concerns, it's very easy to talk about more care closer to home, talk about virtual wards and such things, moving more care into the community. But how to actually do that? We need the right infrastructure, the right commissioning, the right skills, the funding for investing in equipment services. All of that actually needs to be in place. If we don't do that, there are significant risks. The care in the community will potentially be more dangerous than what it is in some of the worst of the hospitals.
I guess we've had some local learning in Kent quite recently with our some of our equipment around telecare. We've been quite transformational, I suppose, in making sure that we've got telecare available as a mainstream service. And part of that response is around actually getting the kit into people's houses. Now, in terms of the conversations we've been having with our practitioners, the message has been, please, make sure that you're considering telecare, maybe rather than a dollop of home care, if it makes more sense to provide that kind of equipment. But at the same time, you need to make sure that you're having conversations with the equipment supplier so that the demand doesn't outstrip supply, and that as part of their business planning, particularly where you might have bigger areas of growth, it's really important that you get that right. Which I think, I was reminding myself of some of the guidance in the CECOPS guidance, was actually it's really important as commissioners that we articulate to suppliers how much activity we're expecting to take place over time. And I think we need to get smarter about how you might project that into the future as well.
Thank you. James, Lawrence, James, do you have a view on this at the end?
Sorry, yeah, I didn't hear that, sorry. Carry on. No, I couldn't hear what you were saying.
Do you have a view on this? Do you want to speak?
No, sorry, I couldn't hear what you were saying, so carry on.
Okay. Just put the safety issue into context. A friend of mine used a lift on a vehicle. Lift failed, he fell off, broke his head open, died instantly. What went wrong? Was it equipment? Was the training? Was it user use? That's what goes wrong when we don't get this right. It really is quite serious. And we know Brian will give you the figure. How many deaths are there every year, Brian, through equipment failure?
Approximately 30, with approximately 1,500 serious incidents. And that's directly related to equipment. That's not people developing pressure ulcers as a result of not getting equipment. That's directly related to equipment. Okay,
well, let's move on to a fourth question then. Here's a good one. How can we ensure services are effective, safe and high quality? Some of us going now to open market and all sorts of approaches where you buy in the commercial market. And I've had some people trying to sell me some wonderful stuff. It was great stuff, just wasn't what I needed or wanted, but it was great stuff. And it would have been great for somebody, just was the wrong stuff for me. But they were trying to sell it to me. Why? Interesting. Okay, over to the panel.
Well, I'll have a start with this. I think there are issues here about the way in which the market operates here, which is certainly outside the scope of CQC regulatory function. And I'm sure we'll hear something about commissioning and possibly trading standards and so on. But I think essentially, from a regulatory perspective, this is an area of care delivery that I think will form part of our proposed change to the the regulatory model that we want to introduce, we will be introducing over the next 2, probably 3 years when you consider the scope of areas that we have to regulate. But I think essentially we're going to frame our regulation and our approach to regulation around 5 simple questions rather than an endless number of standards. And essentially those questions will be which are really relevant to people's experience of care and use of equipment in particular, about is this safe? Is what is being offered safe? And is it effective? And it's in particular, I guess, around 2 of those 5 questions that this will be relevant. And I think when we start to inspect in this way against these specific approaches, these specific questions, we will increasingly bring very specialist inspectors into that inspection regime. So as we start to look at what services are like for people and indeed for their families who are supporting people, we'll begin to look at the extent to which those fundamental requirements and those fundamental needs are being addressed and are being met in ways that are safe and effective and making a difference for people. And they will be fairly fundamental. And the intention is that a failure regime, a new failure regime with increased powers that will be given to us, will focus on those services where those fundamental standards simply aren't being met. So I think the kind of example that Bert has given to us, where the catastrophic end result of a failure to deliver even basic or fundamental care results in the death of a person, will be very much the focus of our regulatory activity. And we will bring specialists to understand this particular area of care delivery.
Pauline.
I think this is quite an interesting one, because this is all about independence. It's about people taking risks, and it's about us supporting people to take risks. That doesn't mean to say that that particular example is at all acceptable, but that has got to be something you learn about. Every provider, everybody involved in this chain, the supply chain of equipment, has a responsibility around specifications and standards, but it's also about understanding the environment that people are going to use it in. And there's another statistic, which sadly I don't have. Somebody here might have it. But there's an awful lot of people who can't get out and about. There's an awful lot of people who can't do things because they're not given the opportunity to take the risks. And there's an awful lot of carers who struggle and have back pain, shoulder pain, all those things that we know about. And equipment plays such an important part in supporting those people to do a really, really tricky job in environments that are not built for care. So I think to make these services effective, safe and high quality is a huge challenge, because there are those competing priorities in the system, and we've got to do our very best to get it right and try and make sure nobody has a catastrophic event.
Yeah, thank you. Brian, do you want to finish off on this one?
I think through my own experience, I used to be an advisor at the Welsh Assembly Government, and part of my role was setting up partnerships. And for me, you have to understand the need. I mean, these are very basic principles. You have to understand the need, have the funding that relates to activity, and have robust commissioning in place. It's the top of the pyramid. If you get that bit wrong, essentially, it's going to not be as safe or as effective on the ground as possible. So, good commissioning, and the code covers that. It covers the commissioning principles in relation to these services. So, good commissioning is key to this, and not just in isolation, in partnership, in working, looking across health, mobility, work, housing. So, commissioning across the spectrum, and the health and wellbeing boards potentially should be looking at something like that, but equipment fits in with all of that.
Thank you. Okay, disability equipment does no little than change lives. It really is critically important. So I suppose our last question now really talks about the code of practice. How can it help, working with CECOPS, to maximise the potential of disability equipment. So who wants to start? You want to start on this, James? Yeah.
I can hear that one, Bert. Sorry. Yeah, I think one of the key aspects of CECOPS is it provides a structured framework within flexibility, and one of the key processes within that is the accreditation process. This enables us to provide a third party review or an external review of how an organisation is doing. So there's an assurance then to those people that are using the service, and also it can give a slightly different perspective to both users of the service and also those working within the service. I think importantly that the process for accreditation focuses on supervision and recognition of work done, and it doesn't penalise or encourage people to just achieve the requirements of a standard, even if those requirements are not to their own benefit. So there's a key requirement there, the ultimate aim to achieve accreditation, which really flags up the organisations to say, yeah, we've made a difference.
My organisation is the only one, was certainly the first one to receive accreditation for CECOPS for equipment. And I can tell you what the impact of that was. And the first one that makes me smile is the smiles on staff's faces. The fact that people took such delight that their work was appreciated and had achieved a standard. And it wasn't just me or their managers telling them they'd done a good job, but it was somebody outside who'd, I'm afraid, turned them over to make sure what they were doing was without flaw. I think for me it was very helpful because it was an independent view. Because if you look at something every day yourself, sometimes you just don't see it anymore. And that was really important. And the third thing is, it's quite interesting the impact it is having on some of our customers, some of our service users, because they like to know what kind of company, what kind of people they're dealing with. And with all of the press there is about sort of rogue dealers and all those kind of things that are on television, lots of our more vulnerable older people and so forth are quite rightly concerned. So it's another way of saying, hey, there's a reassurance in this. So for us, it wasn't a walk in the park to get it, but it was worth doing it.
From a commissioning perspective, I think actually the guide, I mean, certainly for us is quite timely that it's there. Nobody can have failed to have noticed the massive change that's gone on within health and social care over the past year or two. And I think that maybe some of the expertise has been lost where people have left organisations. We've lost some of the organisational memory. And we've got different kinds of organisations and different kinds of people working with us now. One of the sessions I was in earlier was talking around the potential contracting out of commissioning support to the clinical commissioning groups. And so if we start to see the likes, I won't mention names, but other independent organisations that maybe aren't coming from an NHS or a social care background, it's really great to have some kind of rigour, some kind of quality assurance from a commissioning perspective, some hints and tips about the kinds of things which need to be built into contracts in order to make sure that effective and efficient and high quality equipment services are being provided. So I think just one more thing I wanted to add was in relation to the guide, it also enables there to become some kind of level of standardisation. So I think that's useful in relation to performance indicators that might be expected from equipment providers, what kinds of outcome measures, and of course that's contained there as well within the appendices of the guide. So I've had a look at that, and it's really made me think about what we do and what we measure.
Okay. Just lastly, Bert, the code itself, I wrote the code of practice, and I wrote the code of practice from the service user's perspective. There's code standard 45 and its involvement of users and carers, and that's not, does anybody know anybody in a wheelchair, bring them to our meeting. That is, they're actively involved in the design and development of services, and in the accreditation through DMV Health+Care when they're doing the assessment, if you don't meet code standard 45 you fail the overall assessment. So it's having service users actively involved in the design of services. For me, that's essentially what it was set up to do. And it's about getting the right, I mean, this is basic and you will know it, but it's about getting the right assessment and the right equipment at the right time and the benefits that has. And also meeting the whole life needs of the service user, not just the immediate medical need or clinical need, but the whole life needs, allowing them to access school, work, housing and such things. So, and it provides a framework. I mean, James touched on it there. At present, we don't actually really know how we're performing because there's no common benchmark. We're just measuring ourselves against how we performed last year, but how are we performing against neighbouring areas? So the code itself provides a framework to work to and a benchmark.
Well, thank you. Now, this room has the soundproofing qualities of the central runway at Heathrow. We're allowing for that. Just a few minutes left. Would anybody else like to ask any questions? Or are you also exhausted and knackered? What you need is some good disability equipment to get you home. I can see this. Any questions? Okay, brave lady at the front.
Thank you, that was really, really interesting. You did touch on how important it is to have the right training to avoid potential catastrophes and not being able to make the most of that equipment. So, I mean, I assume it is in the code of practice, not just assessing correctly, installing the equipment, but also making sure that the service user can benefit from it and it's maintained correctly in that kind of ongoing process. So I wondered if you could expand on kind of that point, whether you found that was a particular area that really needed improvement, so kind of the training and maintenance of the equipment once it's installed.
Okay. Training it's an important part of this at all levels. I mean, I'll not bore you with all the details, but we're currently in the process of developing an undergraduate award and a postgraduate award with Coventry University. But we've also got approved training, one-day training. Training is also incorporated into the code of practice, and the assessors will be looking for that. And that is, because sometimes, quite bluntly, sometimes equipment is dropped off to a service user's house without any training whatsoever in its use. Sometimes electrical equipment, and we've covered that comprehensively in the code, and it's in relation to the complexity of the equipment. So if you've got electrical and equipment with hydraulics, you've got the equivalent training put in place to support that.
Gentleman in the back.
My apologies, I missed the start of the talk, so you may have answered this. Is this a scheme that is voluntary or mandatory? There's a sum associated with being a user. This is something that seems to me needs to be mandatory regulated. After all, we have care quality commissioners that monitor health-care. Why not have some of the policies, the quality of our disability equipment?
Sorry, I'm finding it difficult to hear the question.
The question is this mandatory or voluntary, the CECOPS scheme at the moment?
Okay.
Right, and also, we've got the Care Quality Commission. Why do we need CECOPS?
No, we've got Care Quality Commission.
Yeah, so...
have anything that mandatory regulates the quality of disability equipment? And is there a role for something along these lines being a mandatory scheme? Where are you along that line?
Okay, I'll touch on the first bit and then hand over to Alan on the second bit. It is, it's voluntary. CECOPS itself, we're completely independent. I did touch on one of the slides about its indirect regulation, but it's self-regulation. It allows you to monitor and assess your own compliance with the various pieces of regulation and your legal and welfare responsibilities. It allows you to do that yourself independently. Now, what we're currently doing, we're talking with Health and Safety Executive Care Quality Commission to make sure there's no duplication and to make sure that areas are comprehensively covered, because there's some aspects of commissioning, for example, the Care Quality Commission don't look at, but the code do. So is there areas where NICE, Care Quality Commission, Health and Safety Executive would recognise our work? So it's voluntary, it fits in with your existing legal and welfare responsibilities with the regulators where equipment is concerned.
It's a really good question, so thank you for asking it. CQC doesn't mandate anything to anybody else. I mean, what we would say, in actually all of the sectors that we're responsible for regulating, increasingly, is that where sectors or providers in sectors are able to demonstrate through any one of a number of schemes or standards, whether these are professional standards or any other kind of standards, that they utilize those, that they measure themselves against their services against the use of those standards because they're recognized either professionally or in some other context. I mean, clearly that's quite important. We work with a whole range of organizations. We work with sector skills councils who produce all sorts of guidance around staff training, about staff capability, about staff support, about staff supervision. We wouldn't endorse any of those particular approaches, but recognize that there are structures, bodies, organizations that work across the health and care system, that develop standards, that try to ensure that through their work, the embedding of those standards and the use of those standards will continue not only to assure fundamental safety and quality of care, but contribute something to the improvement agenda. So we don't mandate anything, but I think clearly whatever the evidence sets and whatever the evidence base is that exists amongst providers across all of their activities, that's worth us considering and us worth looking at. Some work we're doing with a whole lot of home care and care home providers about data they're collecting themselves regarding outcomes is stuff that we're interested in into the future to see whether that becomes part of an admissible evidence set. I mean, I think we're some way off of being in that position, but I think that's the kind of way in which we need to think about this in the longer term.
Thank you. Unfortunately, we need to bring this to an end now. So, a friend of mine works in a care home, and he's the caretaker. He's the guy who changed the light bulbs. And he was asked to repair a hoist. And he pointed out that he'd never repaired a hoist in his life before. So I said, well, look, it's only a hoist. You must know what to do. He refused to do it. Now, he actually didn't lose his job on this occasion, but he might have done. Now, had he repaired that hoist, somebody could have had quite a serious accident. So the hoist wasn't being used. If the hoist was maintained and was the right hoist, it would save the backs and the health of a lot of the staff. Quite often it seems to me that what's happened with equipment, it's been the extra, the expensive extra, the thing that can be cut because it goes into a budget. There's already a budget for staff who are off ill because you couldn't use the equipment or equipment didn't exist. There's a real cost of not having this stuff, which we need to build into our budgets. We also need to take a very broad view about what we mean by disability equipment and community equipment. I remember for years I used to buy an electric tin opener. Do you ever remember these things? You had to screw them onto the wall or get someone to screw them on for you. And they were heavy. And you put your tin in, you wind this thing around this great cranking handle, and about 5 minutes later the top would come off. And about every year this thing would fall apart, it would rust. So you had to get another one, another 35 quid. And then one day I was in Woolworths, as one used to be able to do, before Woolworths went bust. And they had this little device, 2 quid, cut round the side of the tin. You've all got one at home, haven't you? Dead cheap, lasts forever. I've had one for 10 years now. Which is disability equipment? The thing the equipment shop told me, which I had to screw into the wall, lasted 1 year, and cost me 35 quid a year, or the little device from Woolworths. 2 quid, did the same job. And Heinz Wolff, Professor Heinz Wolff, some of you might know him from the Great Egg Race. Heinz Wolff used to argue that we shouldn't talk about disability equipment, we should talk about tools for living. What is, in principle, the difference between a communication aid for a school child and a washing machine? In principle, they're both there to enable you to do something and using technology to help you do it. So we need this very wide view of what equipment is and what it can do for us. And as life goes forward, it's not going to be things like wheelchairs. We haven't even got that right, but that should be so simple. It's going to be telecommunications. Maybe the most important bit of equipment will be some app on your telephone. Yeah. We don't know. This is how it's going to develop. You need to be in there, you need to be up there, because this is not going to be the option extra. If you get this right, you will save a fortune. And what's wrong at the moment is people are not getting it right, and they're paying a fortune. So the answer is there. It remains for me, really, to thank all the speakers for coming. Thank you for coming. It's been a long day. I'm sure all of you are just ready to go home and lift something agreeable to your lips. Enjoy it. Thank you all very much.